All right, we'll call this meeting to order of the Special Committee on Access to Quality Health Care. I know Representative Fry is joining us by Zoom, and we will begin with House Bill 164. Representative Douglas, please step on up and get started.
Committee, thank you for hearing this bill. I know everybody else has other committees, so I'm gonna get right to it. It's a short and sweet bill. I just wanted to introduce this legislation to help not just my constituents in House District 78, but for all Georgians that are on prescription drugs. And this pandemic has caused us some hardship. And everybody, especially our working professionals, our working families, and our seniors have been hit really hard. And so House Bill 64, I'm going to be reading from a sub LC 345745S.
We have a 5758S is what we have.
58S, correct.
So that is the one you're using.
Yes, sir.
Thank you.
All right. And this law really only affects individuals who pay 100% of their premiums. People like on our state health care plan, our teachers, police officers, firefighters. This bill was also allow for them to receive 80% rebate at the pharmacy counter. And you know that people who are on insulin, who have to get their drugs every month, this can be very encompassing to them with the prices. And this rebate would really help them. Point of sale purchase with the drug insurers will still keep the 20%, the insurers will. And so the current law states that the insurer keeps 100% of the rebate and the patients are only allowed 0 at the present time. So with this transparency study shows that only 1.5% of the rebate money goes to the premium for the patient. And so that's the short of the bill. It's very short and to the point. I'm just trying to help the people who not necessarily have been on drugs before. I want to help them too, but people that's coming out of this COVID and we're still in it, I want to be able to help them at the counters too, because some of them are going to have to take drugs after this is all over, after we get to herd immunity. So, Mr. Chair, that is the bill. I stand for any questions. I do have somebody on Zoom who is a professional about this with Farmer, can answer all these technical questions. Don't shoot the messenger. I'm just here to present the bill and see if we can make a happy ending.
Certainly a strong goal to try to protect prescription drug costs for all Georgians. Representative Prince.
Thank you, Mr. Chairman. Representative Douglas, I just want to make sure I get the gist of this. This bill is to provide a rebate for those who pay 100% into the state benefit plan. Is that?
Yeah, for single pay insurance.
Single pay. Okay, thank you.
Anybody who's buying their own insurance, not on a group plan, but single pay insurance. Yes, sir.
Thank you. How about online, Representative Fry or any others with, just make sure you raise your hand. We'll watch for that if you do have a question. Here's Representative Bentley.
Yes, sir. Thank you, Mr. Chairman. And thank you, Representative Douglas, for your work on this legislation. I'm just for a point of clarity, as you reference COVID patients, we all know my husband's situation, battling with COVID and he'd been in the hospital down in Savannah. And now as a result of this COVID, he's going to have a whole lot more medical prescriptions that we're going to have to fill that we're going to Jones back home. So this bill is going to help me save money at the pharmacy as I'm trying to just, take care of all these additional medications that he's going to have to take now. Because as a result from COVID, he suffered some brain issues And so now we're going to have all these medications for seizures and things of that nature. So this bill will be something that can help me as I try to prepare for his return home.
Yes, ma'am. If the committee will allow it, yes, it will, totally.
Chairman Houston.
This might be a technical question you might need to ask, but anyway, this is for commercial insurance plans and people pay their whole premium, correct?
Not commercial, individual plans,
It's not for commercial individual plans.
just individual plans, like people that have lost their job and come off a group plan.
Yeah, well, that's what I sort of think about if you buy a commercial insurance plan, maybe. Okay, if you're paying for the whole premium yourself, this would make a difference for you. Well, who gets those rebates now if you're paying for all the premium? I understand if you're on a group plan, they negotiate to get your premiums down, but right now, what happens to those rebates? If you're paying for all the premium yourself,
Right
who
now,
gets the rebates?
right now, the people that are in the middle, the insurance company, I don't know, that's a technical one, if I can, oh, the PBMs get that money now.
Oh, okay, I didn't know who got it. Okay, all right.
The people in the middle, there's a drug company, there's a PBMs, and there's consumers. So the people in between the consumer and the drug company.
All right, thank you.
Yes, ma'am.
I have a question, if you don't mind, on the page, lines 87 through 91.
87.
And this also may be a technical question, which feel free to, but the no publicize or otherwise disclose information concerning the actual rebate. How do you protect that confidentiality of the rebate amount when the patient gets the rebate? Or I guess they never know what it would have cost without the rebate adjustment? Or how exactly does a pharmacy or an insurer protect that somewhat private information of the rebate they've arranged with a drug manufacturer? When it gets to the patient, how do you still keep the number secret?
Could I use one of my lifelines?
I need a lifeline just to get the question right, but if you want to defer to your presenter,
my person online, my professional.
we'll definitely do that. Let's see if we can set that up right now. This is, if you can just introduce yourself online and then tell us what your role is here and then begin. Is it Zach Poss?
Sure. My name is Zachary Poss. I'm a director of state policy with PhRMA. We're the trade association that represents the brand manufacturers of drugs, and happy to answer that question. When a patient goes to the pharmacy, the pharmacist will provide them with their cost information. What this bill would do is, on the back end, the patient's not seeing this happen, but on the back end, at least 80% of the rebate would be applied to the patient's deductible or coinsurance payment. So if, let's say, normally they would be paying $100, but the rebate was $50 and 80% of that was returned to the patient, that's $40 rebate going to the patient. So they would see that they're paying $60. They don't necessarily know what exactly the rebate amount is. That's why we say at least 80%. Insurers and PBMs can choose to offer more to the patients at the point of sale, but at least 80% of that, similar to health plans' medical loss ratio, would go to the patient at the point of sale.
Feel free to, if you had some other part of your presentation to go into, we'd be glad to hear from you now.
Absolutely. Thank you. I do want to thank Representative Douglas and the members of the committee for really considering this very important issue for Georgians. It's a bill that will give patients the benefit of the significant rebates and discounts that pharmaceutical manufacturers pay to insurers and PBMs, the middlemen that Representative Douglas mentioned. On average, about half of the drug's list price is paid into the supply chain in the form of rebates and discounts. And in 2019, those rebates and discounts totaled $175 billion. But as has been mentioned, patients are still experiencing this financial hardship at the pharmacy counter. As one of the other representatives said, her husband is having to take a lot of new drugs because of COVID and is going to face significant, it's a big financial drain when you have lots of medicines to take and you have to make choices. But the reason that this is such a huge financial drain is that for patients who are in the deductible phase or are paying coinsurance on a medicine, the amount that they're paying is actually based on the full list price of the medicine, not what the insurance company or PBM negotiated with the manufacturer. And what's even more interesting is that this situation is unique to health insurance coverage of prescription medicines, and it penalizes patients who really need those medicines. If someone is going to a doctor's office or has to go to the hospital, they've received the benefit of negotiated discounts for that visit, but they don't receive that same benefit for prescription drugs, and that's what this bill aims to do. Another thing that we've heard insurance companies say is that they use the rebates to reduce premiums for all members of a health plan, and that redirecting rebates would cause substantial increases to premiums. But there are a couple of issues with this. First, studies have shown that if rebates were shared with patients at the point of sale, premiums might go up as much as 1%, but patients could save up to $800 a year. That's not a small amount. And second, and I think this is kind of more the core issue, if health plans are taking these rebates that are intended for sick patients and applying that money to healthy patients, what you have is the sick subsidizing the healthy, which really defeats the purpose of insurance. So as Representative Douglas has proposed, by giving patients the benefit of the rebate at the pharmacy counter, we can start to provide direct and immediate relief to help Georgians afford their medicines.
Thank you for your presentation. Are there questions for the presenter at this time from the committee or online?
I just want to add one thing, Mr. Chairman.
Sure, Representative Douglas.
I don't know if we had a chance to get it in the packet. It is in the packet. There are over 40 companies that support this bill here in our state. And this is a very, as they say, plethora of companies that support the bill.
Thank you. Seeing no other questions, we do have others signed up to present on the bill. Thank you. At this point, Jesse Wethington, please come on up, just identify yourself for those online and us. And
Thank you, Mr. Chairman, members of the committee. Good afternoon. My name is Jesse Wethington. I am the president of the Georgia Association of Health Plans, which is the commercial trade group representing Georgia's commercial benefits and individual health benefits industries, covering the small group employer and individual markets. I have to rise to respectfully oppose the gentleman's bill this afternoon. Our members are opposed to proposals like this that we've seen crop up around the country because it does get to the issue of how our current practices are versus, the state that's going to be proposing the legislation. We do currently receive rebates that are negotiated between a PBM or a PBM and insurer on behalf of a plan sponsor or group pool. And those rebates are negotiated in aggregate based on different drugs with the manufacturer. And then those rebates are taken and applied to the whole pool to reduce everyone's risk and premium over the course of a year without having to get into an individual's disease state, picking a preference or something over another. And that does get to the general principle of insurance, which is pooling and aggregating risk for a body of people so that their spending can be smoothed over a period of time. Again, we oppose this bill. We would like to continue being able to do our current practice, which is passing the savings that we get off in rebates to premiums, both on the individual and plan sponsors basis. There are some issues, Chairman, you pointed out that we would have some difficulty calculating what this amount was at the point of sale to return it to the consumer. Again, these are negotiated sometimes or adjudicated about a quarter in arrears. And so there would be an issue with what is that actual calculated amount. That would be difficult for us to do. I have not seen the substitute of the bill either. The original does include via reference the state health benefit plan. And I would add that this would have a fiscal impact on that bill and therefore should have a fiscal note per the requirements of the SHBP Fiscal Note Act. That concludes my remarks. Any questions for the committee, I'd be happy to take.
Any questions from the committee online or in person? Do have one. Representative Bentley.
Yes, sir. Thank you, Mr. Chairman. So I'm sure you heard me mention earlier about my personal quick story. And my primary purpose for sharing that, because I want people that's watching and listening in this room to know that, sometimes patients with COVID come out of the hospital with a whole lot more issues to deal with prior to going in, a lot more medications to try to purchase. So your opposition is going to do what for me, considering you've heard my quick personal story?
Yes, ma'am. And I certainly appreciate your involvement in the situation. So what I would say to you is that you're currently getting the benefit of the rebates now in terms of a lower monthly premium that you're paying every month and everybody else on that plan is paying every month. You would be faced under this bill with lower potentially out-of-pocket costs on an individual basis as a family, while everybody else, including yourself and your family, would be paying for it in a higher premium the next year. So it's really a trade-off about where the risk is getting priced into your care. Is it at the point of sale at the pharmacy, or is it in your premium? There's a mechanical relationship between the cost sharing that the member has and then what the premium winds up being either this year or next year.
I see no other questions. Thank you for your presentation.
Thank you, Mr. Chairman. Members of the committee.
Cash Travetti, come on up and identify yourself if you will. And
Thank you, Mr. Chairman. Cash Travetti with PCMA, the National Trade Group for the Pharmacy Benefit Managers. And we rise today and respectfully oppose House Bill 164. Rebates are used by PBMs to save consumers money. Rebates help keep healthcare costs down across the board. PBMs don't help the majority of patients who take generics or lower cost drugs. They're usually for high cost, competitive branded medications. Additionally, 90% of drugs dispensed are generics as they sit now. According to a recent GAO report, 99.6% of all rebates are passed back to the drug plan sponsor. With that, I'll conclude my remarks. If there's any questions, I'll try to answer.
I see no questions. Hold on just a moment, Chairman Houston.
I've got a question. Why
Yes,
don't the
ma'am.
pharmaceutical companies just charge the price that it should be and stop all these rebates and we all wouldn't be in this mess?
I can't speak for the pharmaceutical companies, Madam Chair.
Thank you.
Thank you for your presentation. This has been a hearing only. Obviously, this is a complex situation in a lot of ways, and many moving parts depending on which section of the insurance code we're dealing with, whether it's fully insured, ERISA, state health benefits, Medicaid. We do want to make sure we give it a due diligence. I do appreciate the novel approach to getting that back directly to the patients in as clean a way possible with the maximum benefit to those who need the medications. And we do commit to looking further at this, and we'll have to try to do it pretty quickly with some dates looming. But we appreciate everyone's participation that came to discuss pharmaceutical pricing and ways we can make it better for Georgians. So thank you for your bill and your presentation today. If we can right now, we've got the one other bill on the agenda for today. It's a fairly recent addition, House Bill 697. The LC number is LC 460424. And this bill I authored along with co-sponsors Chairman Hatchett, Jones, Cooper, and Houston. Over the past 10 or 15 years, as health records have gone from paper records and walls full of files in doctors' offices and entire floors in certain hospitals, we've electronically transitioned medical records in a much more accessible manner, and that has been actually supported by taxpayers, both federal and state, to the tune of billions of dollars. one of the major goals of this expansion and transition to electronic health records was to try to use that information to minimize duplication of services, to speed up the access. When someone, for example, is sent to a consultant, the consultant would have access to what maybe the primary care doctor or an emergency room or another hospital had done, so that they don't have to start from scratch each time, but they can all share their medical records. I can tell you the sharing was moving along in the early teens as meaningful use standards were changing and evolving. But somewhere along the line, the information sharing got a little sidetracked. And so we have large electronic health record vendors whose systems are capable of talking to each other fairly freely, but they don't. Obviously, the people who suffer from this are patients who are required to have a duplication of services. For example, if somebody was in an ER last week and now I see them in an emergency department, and they had an MRI, but I have to decide, do I fax off a patient information request to the other place, or do I just repeat the MRI? Obviously, that affects both cost and the exposure of the patient to possibly unneeded services, plus delays. So what this bill seeks to do is not to try to correct that at this point. That's beyond the scope, I believe, beyond the scope of this legislature, because a lot of the companies are outside of Georgia. What this bill seeks to do is to at least do a survey of the hospitals who almost universally use electronic health record vendors, for which they pay hundreds of thousands or millions of dollars many times each year with per provider licenses and an entire health record system, maintenance software, updates, all that's required to keep up with the complexity of electronic health records or health records in general. What this bill seeks to do is to add a few items to the annual disclosures that are required by the Department of Community Health. There's already a lot of things, and if you look in the bill, you'll notice a tremendous amount of things that are not changed. Gross revenues, bad debts, just on lines 69, the number of people treated regarding indigent care. There are already a lot of reporting that's done annually. The Department of Community Health is really unable to add what we were trying to add without specific legislation. So the specific legislation attempts to ask three things of a hospital that uses an electronic health record. First off, it assumes they use an electronic health record, yes or no. Does it provide meaningful information exchange with the requisite definition cited in the legislation? If it doesn't, what are the barriers, and is there a timeline for eventually offering more robust information exchange? That is the extent of the bill. It does exclude hospitals that may not have the bandwidth to have a sophisticated system in counties that are determined to be rural, which we define in line 46 as less than 50,000 in the 2010 survey. So it will exclude some of our hospital systems and health systems that are in our smaller counties. They could still participate, but they wouldn't be required by this legislation. And frankly, the hospital can actually just make it a requirement of the contract with their electronic health records vendor to answer these. They can delegate that. They obviously are still responsible for the veracity in the report, but that can be delegated to where it's not an additional duty on the hospital as much as it is something that contractually they would get their electronic health vendor to answer. And so that would just be a survey. It would tell us where we are. It would tell us we're going down the road. It's going to take several years to get the information exchange that providers need and patients deserve. But I think we can make a small step, I believe, by at least adding to the annual hospital disclosures the language in this legislation regarding interoperability, health information exchange. So I'm glad to answer any questions at this time. We do have someone who will speak on it, but I'm glad to answer any committee questions. Representative Prince.
Thank you, Chairman. So is this bill sort of from the Department of Health Services?
Well, it is.
Are they requesting this?
It was. No, they are not requesting this. They don't. They have not taken a position on whether they think meaningful sharing of electronic health record information to assist a patient. I don't think they don't oppose it. They just said they could not regulatory. It looked like they had the regulatory ability in my review maybe a year ago when we discussed some of this legislation. They said they would need specific language from the legislature for them to be able to mandate that a hospital give this information. So this is a survey to say, where are we now? Do you have plans to make it better, and a timeline? If not, what are the barriers? And that will just give this body the opportunity to look, maybe there's ways we can help eliminate the barriers. But this is just a first step in getting information.
So is it, I guess,
Go ahead.
fair to say that they would sort of help build this survey to get
Right.
the information that they need? Because I'm
Exactly, and
That's
they'd
right.
report it to the legislature. It'd be available for us to review. I believe we have online Chairman Perkle. Are you there?
Yes, sir. Can you hear me okay?
That's good.
Thank you so much. And you basically answered my question with the last, this is just a survey and we're trying to gather data. Ultimately, what we're looking for is better patient outcomes depending on how this survey comes out. But this is just a survey to gather data to see where we're at and how we can maybe better address patient outcomes, to determine patient outcomes. Will this be very time consuming for our hospitals, do you think?
Well, I don't believe there's been nothing's been told to me that this would be a significant increase. I do think there's been some support for this, for the fact that it's in an annual survey, that they're already a timeline where they're already having to gather pretty regular information. They've been doing it every year for all the things that are currently in the bill, but you summarized it very well.
Well, thank you. I think more data is what we need, and this is a good bill. I appreciate it.
Thank you. All right, we'll go on to our presenter on Zoom. Is it Jamie Lord? Are you there?
I am here. I'm Jamie Lord, and I represent the Georgia Association of Clinical Social Workers, but I actually have one of our members who practices in the field, William Smith, who actually is probably better suited to speak to this issue, if that's okay.
Sure, certainly. Go ahead. Just have him
Thank you.
introduce himself one more time.
Hi, yes, thank you for having me. My name is William Smith. I'm a licensed clinical social worker, a licensed psychotherapist, and the legislative co-chair for the Georgia Society of Clinical Social Workers. I'm also a member of the American College of Healthcare Executives. I'm here today. We're not necessarily opposed to the bill. We would certainly like to make our voice known about special circumstances, special accommodations for psychotherapy notes. There's a few things where we actually believe that it could be dangerous for open access to psychotherapy notes. The examples that I like to give are, for example, children involved in divorce cases where the notes may be used as ammunition for the parents in conflict. Domestic violence cases is another good example. For example, if there was a woman involved or whoever involved in the domestic violence case and their partner was somehow able to access these notes, we know that domestic violence cases are oftentimes precede murder-suicides. So these and there's a lot more examples, but those are some of the in my opinion, the more noteworthy ones. And so we just wanted to go on record as saying that we would like for psychotherapy notes to be exempt from this bill.
If I can, I'll be glad to respond. Nothing in this bill is going to open up records at any point, and that would be probably several years down the road before the exact amount and type of data sharing that would be done. So nothing in this bill would ever require, frankly, any hospital to do anything more than what they're doing today. This is simply a request for some information from the electronic health record vendors. And I completely agree. Some information, all health information is sensitive. Some is even especially sensitive and protected for good reason. There's multiple categories of that. And the situation you described would certainly be one that I believe years down the road, when possibly health information exchange becomes more robust or capable, would be properly excluded at that time, or especially protected. So I want to assure you, nothing in this bill is going to open up anybody's psychological records, clinical records, drug use records, anything else now, and nor does it intend to in the future. So thank you for bringing up the concern that all health information, but especially some areas are even more sensitive than others. But thank you for your presentation. Thank you. Are there any other questions from the committee or? Yes, sir, Representative Prince.
At the proper time, I'd like to make a motion.
If there are no other questions, now is the proper time.
Move that we do pass.
We have a motion and a second. Is there any other discussion or questions from the members online? Just please hit the raise your hand button. I'm sorry, raise your hand if you'd like to discuss further, and then unmute your microphone and talk to us. Okay. If not, all in favor of House Bill 697, LC 460424, say aye.
Aye.
Online?
Aye. Aye.
All right. Any opposed? No. All right. Thank you. The bill passes on to rules. Thank you all for being here today and working with us.
Yeah, I put the alcohol on. Oh, you don't put some on? Yeah, I put alcohol on it. But I found one, a big one like that.
Oh,
Same
okay.
size?
Mm-hmm.
Okay. Yeah, that